So I hope everybody can hear me. So thank you very much for coming here with me for this. It's an informational webinar for patients, patient caregivers, people who are involved into care of the patients. So this seminar is meant for people who are on active treatment, some form of active treatment. Patients who have been treated with cancer treatment in the past, presently they are on follow-up, asymptomatic, or they are on a routine screening modalities, or people who are caregivers to such patients, or you are just an information seeker who needs more information regarding this topic, and medical students or medical staff who needs more information on this topic can also hear me out. However, I believe that medical staff will feel that my information is pretty superficial for them. Now, this seminar is not meant for few people. For example, people who are looking forward for information about corona prevention, this webinar is not for them. People who are not involved in cancer care may feel that this information which I am being sharing with them is absolutely not relating to their cause. Then other medical oncologists whom I believe that they are already aware of the updates which I am going to discuss, and few cancer patients or cancer caregivers who are planning to consult me over this platform may not find it useful because I'm not going to consult any specific case here. Now, coming to the basic structure of this presentation, what I will be covering is, I will be covering few basic terminology in cancer treatment, which is important to understand regarding how we triage patient. Information about the treatment options other than chemotherapy, because chemotherapy is what we are afraid of, and how we triage the patients, and a brief one slide only about the telemedicines for cancer patient amid this lockdown, where telemedicine has been approved by the government, and what are the limitation of e-prescriptions for cancer patients. This presentation, this video recording will be freely available over my website, so feel free to download it, share it. Now, few basic terminologies are, the first thing is whether we are talking about solid cancers or liquid cancers. Liquid cancers also is known as hematological cancers, blood cancer, or blood-related cancers. So solid cancers include examples like breast cancer, lung cancer, stomach, pancreas, prostate, brain cancer, anything. The common notion of the public of staging, that it is stage 4 cancer or early stage cancer, is basically applied to this solid cancers. Liquid cancers, where with leukemias, lymphoma, staging is not important, even though there is a staging, because most of them we can cure it. So all hematological cancers are expected to be a kind of curative intent, which includes acute leukemias where it is emergency to start treatment, and chronic leukemias where we can postpone the treatment and give a low treatment at present during the lockdown time. Now, coming to the next slide, the basic question what everybody asks to me is, what is a chemotherapy? Now, chemotherapy in simple terms is certain medication which is just given to kill cancer cell in the body. Now, basic mechanism of chemotherapy is to cause cancer cell kill. Along with cancer cell kill, it also causes certain normal cells to go down. So normal cells like WBC, hemoglobin, platelet, or skin lining of hands or mouth. And then because of the chemotherapy, patient develops certain side effects like mouth ulcers or hair loss or hemoglobin going down, WBC going down. Now this WBC going down makes the cancer patient prone for infections. And especially during Corona lockdown time, we want to avoid any sort of infection because of non-specificity of Corona symptoms like fever or cough. Even non-corona infections are being triaged as corona infections and will be difficult to manage at later point of time. Now, usually chemotherapy is given in the form of injections, but in today's time, we also have certain tablet chemotherapies also. I will cover it later. Now, what is the benefit of chemotherapy? The benefit of chemotherapy depends on what stage we are treating. Early stage, which is the local disease, like stage 1 or stage 2, usually it is a surgery which is done first, usually. Based on surgical reports, what we remove out of your body, we offer chemotherapy if certain risk factors are present, certain risk factors which tells us that there is a higher chance of disease coming back. Now, if a disease is slightly more advanced, for example, a breast cancer spread to the lymph nodes in the axilla, the role of chemotherapy becomes significantly more. Now, the intention of this chemotherapy in this point of time is not to just control it, but reduce the disease, reduce the cancer burden, and ultimately reduces the extent of the surgery also. In comparison to these stage 1 to 3, there is a stage 4 where we are not giving chemotherapy to cure the patient, but only to control the disease. And in this process, we also reduce the symptoms of the patient, which can range from pain, nausea, vomiting to breathlessness. This is known as palliative chemotherapy, and unfortunately, major chunk of oncological treatment, major chunk of cancer treatment, especially in India where we don't have any good screening policies, it is palliative chemotherapy which takes role. But palliative chemotherapy represent an important part of section of treatment because we are reducing the symptoms of the patient and improving the quality of life. Now, the next point I want to cover is, are there other treatment options available for cancer during this lockdown time? So surgeries and radiation, which is considered as the main important steps to treat cancer up to stage 3, is presently being avoided because of the corona lockdown. We avoid elective surgeries where we are planning surgeries in a normal patients, um, in not an emergency patient. If any symptoms are there, like local pain where we can give radiation, or local ulceration where we need surgery, we are not offering surgery during this corona lockdown time. In stage 4 cancer, other treatment options might be available, depends on the disease to disease. For example, in lung cancer, targeted therapies is possible in up to 40% of the cases. Immunotherapy can be given, or a gene-directed therapy is given, in which a particular gene is targeted, usually by a tablet. For example, for chronic myeloid leukemia (CML), there is a tablet which target BCR-ABL gene mutation. So these are treatment options available with us. Now, what is targeted therapy? Chemotherapy directly goes and kill the cancer cells like antibiotics, while targeted therapy do not kill the cancer cell directly, but it modify the certain other mechanism how a cancer cell survives in our body. For example, certain cancer cells express certain receptors, certain molecules which are expressed over their outer layer. Now, these targeted therapy can go and bind on these receptors and can kill these type of cell. So, examples of targeted therapies are trastuzumab in breast cancer, bevacizumab in colon cancer, or also used in ovarian cancers, stomach cancers, or in lymphoma rituximab. So, usually these targeted therapies are much less toxic, but usually they are more effective in combination with chemotherapy. There are minor side effects with this targeted therapy in general. Now, word about immunotherapy. Immunotherapy, what it does, it reduces so our mechanism by which a cancer cell survive. One of the mechanism is it makes our immunity dormant. So this T cell, which is a part of our natural immunity, the purpose of this T cell is to kill a cancer cell, becomes dormant if an immunotherapy, if a cancer expresses a molecule known as PDL1. Now, this immunotherapy binds or blocks the combination of PDL1 present on the tumor cell to the PD1 receptors on the T cell. By binding, or I can say avoiding the binding between this PDL1 and PD1, cancer cells can, the immunity cell start working on cancer cells and can kill them. So this is how immunotherapy is there. Since there is no direct killing of the cell, कोई cell directly does not kill other cells. The usual side effects of chemotherapy like hair loss or mouth ulcers usually do not happen with immunotherapy. Now coming to this main aspect of this presentation, why I'm presenting is this lockdown is presenting lot of difficulties to us as doctors, as physicians. It is giving lot of difficulty to the patients, like travel restrictions. Patient cannot travel from long distances. Even if they can travel by taking some passes or special certificates from me, they are at risk of hospital visit, getting exposed to infection or communicating their infection to other patients who are prone for other infections. Other possibilities, other logistic difficulties what we face is availability of medications. So even though hospital is working, the pharmaceutical distributor may not be working at its full power, so medication may not be available to us. Or if we give certain medication through e-prescription, or even if the patient visits to us, they may not be available in normal pharmacies, so availability of medicines goes down. Supportive care limitations are already there. For example, after a chemotherapy, patient needs blood products or antibiotics, then again coming to the hospital poses risk to them. Of course, financial toxicity is already there during this lockdown time, where people are not earning as much as before. Now, in view of these logistic difficulties, as far as possible, we try to avoid patients giving aggressive chemotherapies in which side effects or supportive medications are required more than the low dose of chemotherapies, or in which high amount of blood products are required. We also try to minimize patient visit to the hospital by changing the chemotherapy types, or we are changing how many in how many days we are giving the chemotherapies. So coming to this is how we triage the patient. The most important thing is symptom. If the patient is having symptom of a cancer, then they need evaluation, then they need treatment also. Second most important is, what is the intention? Can we cure this patient? If a patient can be cured, then we give aggressive treatment irrespective of what happens next, because whether he contracts corona or not, it is secondary, but he is having cancer, we have to treat it. Now, what is life expectancy of the treatment, life expectancy of the patient with treatment and without treatment? Is the patient fit or is having a lot of other illnesses? We are going to discuss these 6 points in the next coming slides. So starting with the first thing, if symptoms are present, the cancer patient do not have time to wait for lockdown to get over. We don't know when this lockdown is going to get over. So if any symptom is there in a diagnosed case of cancer patient, or they are having symptoms which are suggestive of cancer, for example, blood in the cuff, or significant weight loss, or significant sweating at the night, such symptoms, then we have to evaluate. Patient should visit to the hospital, get evaluated, get treatment done. So now, as I was saying about what is the intention of treatment, whether it is curative versus palliative, most of the blood related cancers like lymphomas and leukemia, especially if they are high grade or acute leukemias, they have to have initiate their treatment as early as possible, because in majority, when I say majority, it is about 85% blood cancers can be cured. So we cannot delay the treatment of blood cancer related problems or blood cancer related treatment to for this lockdown to get over. We have to start even if we are feeling logistic issues. As far as solid cancers are concerned, like lung or breast, from stage 1 to stage 3, under curative intention, we have to start treatment, because if we wait too long, a stage 3 cancer can become stage 4 cancer, and a curative patient which can be cured may become palliative, in which we cannot cure the patient. However, stage 4 solid cancers, in which the main intention is palliation, treatment, giving aggressive treatment will not change the outcome too much. Our intention during this lockdown time is to control the disease as long as possible with less aggressive treatment, which does not need too much of supportive care, and then take aggressive treatment whenever patient is fit or when this lockdown is over. Now, borderline cases are the cases which are at present not stage 4, but locally advanced. If we give certain chemotherapies, we can reduce the disease, and probably we will able to operate the patient later. Later means when the lockdown is over. These type of patient also need treatment to be initiated at earliest as possible. They don't have to wait for lockdown to be over. Now, life expectancy with treatment. Some cancer, even if they are early stage, stage 1 to 3, do not benefit much from chemotherapy. In the sense that the percentage of disease coming back after chemotherapy and the percentage of disease coming back in the absence of chemotherapy, a difference of 2-3% are there. So we can avoid giving chemotherapy in those patients. For example, stage 2 colon cancers, certain subgroup do not need treatment, while on the patient which we give chemotherapy, there is an additional benefit of 2 to 4%. So we can avoid that. Other example is gallbladder versus breast cancer. In gallbladder, even if we, in an advanced stage, we give some treatment, the benefit is not significant, so we can avoid it. On the other hand, even in certain cancers, stage 4 responds beautifully with treatment. And for example, lung cancer with treatment, we can prolong life for by couple of months. While pancreatic cancers, stage 4, we cannot increase life more than a few weeks to couple of months. So if a life expectancy is significant with treatment, we should offer the treatment. Now, fitness of the patient. A weak patient is either due to because of age or coexisting illnesses. For example, kidney disorders, hypertension, or uncontrolled diabetes. They are already prone for infection. In such cases, we avoid giving chemotherapies because chemotherapy can reduce the WBC further and makes the patient prone. Not only prone, other supportive medications, supportive blood transfusions, admission, antibiotics, everything increases, which is difficult during this lockdown time. One thing I would like to say at this point of time is, if a old age patient or a not a very not a very fit patient is receiving treatment for some reason, it is the responsibility of the caregiver to take utmost care to follow instructions of the physician or oncological team. Many people, because of this lockdown, take this excuse that we cannot buy this medication from outside because it is lockdown, we will take this medication tomorrow. One should understand that this patient who is not very fit or is old is more prone to any side effects of chemotherapy compared to a young patient who is fit, who don't have other illnesses. So if, let's say, you consult your oncological doctor who is treating you and he prescribes certain medications, it is your duty to start those medication without delay. So this is my advice to caregivers. Now, can anything else be given to cancer patient during this lockdown time besides normal chemotherapies? For example, some chemotherapies are more effective. Example, FOLFIRINOX is most effective treatment in a pancreatic cancer, but it is relatively more aggressive. 40% of the patient can develop fever or lose motion on this, which we want to avoid during this time. So we can shift to certain less aggressive treatment like gemcitabine with combination of taxanes. In this, the visits may increase. Now, FOLFIRINOX is given every 15 days, while gemcitabine is given every week. So even though visits are increasing, we are reducing the chances of infections. So we have to balance between the number of visits and what is the toxicity of the drug which we are giving. Can immunotherapy can be given during the this lockdown period? Now, giving immunotherapy does not mean that immunotherapy is going to work on the cancer cell. So as far as possible, a treatment which is working should be continued, whatever it is, chemo or it is the tablets. If you want to change, yes, during this 1 or 2 months of lockdown time, maybe 3 months of lockdown time, if patient is not severely symptomatic, you can give it a try to discuss with your oncologist regarding using immunotherapy. Certain drugs can be given on weekly basis, which is more tolerable. For example, paclitaxel is given every week in a relatively unfit or old age patient. It can be shifted to once in 3 weekly chemotherapy. So number of visits to the hospital reduces. However, chances of immunity going down also increases. So for this immunity, we have certain injections like GCSF, which usually we don't use with many chemotherapies. For example, Folfox, we never use GCSF. But during this lockdown time, I'm using GCSF almost all patients. I don't want any risk of developing low WBCs and developing some infections. Because once an infection comes, fever comes, patient becomes breathless, for any reasons, he will be treated as a suspected case of COVID infection as per the directives of the health ministry. So unnecessary trend may start where patient can develop other infections but being quarantined within COVID ward. So I don't want that. Now there is a new concept, metronomic therapy. The beauty of metronomic therapy is the same chemotherapy agents which we are giving in high dose every 3 weeks can be given in the forms of oral tablets every day. So the patient which may develop side effects because of once in 3 week dose, when we are giving the same dose in small amount every day, the side effect which they develop is lesser, and it can be titrated based on side effect. For example, somebody develops a side effect, you can stop the tablets at home. You no need to come to the hospital. So the examples of this are, in oral medications, we have topotecan, which we can use in ovarian cancers, methotrexate, which we can use in lymphomas, cyclophosphamide, or tablets is also available of cyclophosphamide, pazopanib or geftinib in case of lung cancers. One common combination of metronomic therapy in which all tablets are prescribed on 14 days basis is combination of endoxon, that is cyclophosphamide, and NSAID like celecoxib and combination of methotrexate. This is one of the common combination which we prescribe for breast cancers. So during this lockdown period, I'm actually shifting many of my stage 4 palliative cancer patients from chemotherapy to oral metronomic therapy. So their visits to hospital reduces to minimum. Now, one word especially applicable for our scenario, Indian scenario, our patient, majority of my patients are not insured. So they suffer a financial toxicity because of cancer diagnosis, cancer treatment. During this time, if somebody cannot opt for safe but expensive treatment options, then I should not offer them. It creates a lot of guilty on the part of caregiver, and we can continue whatever they are taking at present, or we can shift to metronomic therapy in that case. Now the last slide of the day. Since government has approved telemedicine, teleconsults for other medications, other branches of the medicine like cardiology and kidney disorders, we as oncologists are still restricted because none of the chemotherapy medications can be prescribed over teleconsult. We have to see the patient before prescribing, and we have to give the prescription on paper. So you have to visit the chemotherapy even for oral chemotherapies. So no chemotherapy can be prescribed virtually. Now, in the world where many patients who are coming to me from outside Hyderabad, West Bengal, Bangladesh, or somewhere outside the city. Now, in this situation, many people ask that can we take chemotherapy outside in presence of a MD medicine doctor or a MEBS doctor? Can we do that? Because we are delaying, we cannot travel, and patient is symptomatic or patient is having stage 3 in which role of chemotherapy is significant. So can we take treatment somewhere else? So what I want to convey is, yes, it is logistically possible. A doctor there can consult with me and take the medicine, because most of the protocols are available free of cost over internet, or your discharge card also contains this dilutions and how chemotherapy is to be given. But the legal responsibility of such chemotherapy administration is of the doctor who is at present giving you the chemotherapy. So let's say anything happens to you because of chemotherapy. So the legal, ethical, and any responsibilities of that doctor who is giving you the medication. So these are the things which I want to cover in this my telemedicine, no, not telemedicine, sorry, modifying the chemotherapy consult. modifying the chemotherapy during this lockdown time. If you have any questions, then we are open to questionnaire. We have 10 minutes in our hand. We can discuss anything which you would like to ask. So this presentation, including the video as well as the PDF file of this presentation, will be available on my website. You are free to download this presentation, distribute among other patients, caregivers. This video you can share over WhatsApp. Feel free. As far as everything is done free of cost, and the basic structure of this presentation should not be changed. Secondly, this presentation is the first time I am doing it. So, of course, there will be improvisations. Many of my presentations will improve. Frequently asked questions, what other patients ask to me, will improve, will be added into this. And so we can expect a few more such lockdown time presentations, and we can expect some improvement over this. If you feel any questions to be asked, then I'm all available. So you can visit my site by the name of my name, drbharatpatodya.com. Also, the same website will be accessed by KNOW, nocancers.in. So the same presentation will be available there. So we have 5 more minutes to end this meeting. Feel free to ask me anything. So I believe it was an informational webinar for all of us. Feel free to contact me at your comfort. I'm going to end this meeting in next 2 minutes. So thank you very much. We are ending this webinar. Looking forward for further participation in future meetings. Thank you.